Hello, everyone, and welcome to today's price transparency workshop. For those of you that haven't begun yet or just getting started, we hope that by the end of this presentation, you'll have a good idea of the requirements and how to prepare for implementation. Specifically, we're going to be covering how to comply with the consumer display and the machine-readable file. Joining me today, my name is Greg Adams. I am the Executive Vice President at Panacea Healthcare Solutions. Joining me today is Henry Gutierrez, who's VP of Financial Consulting Services for the company, Fred Stodolak, who's our CEO, and Renee Clark from Phoenix Children's Hospital, who's the VP of Managed Care and Network Operations. Our agenda today begins with a short two-slide overview of the rule requirement. We will then cover 10 things we feel you need to know, some of which may not have been clear or have gone unnoticed. Renee Clark from Phoenix Children's will then provide a real-world example of their approach to meeting the transparency requirement. We will also discuss the required data sources that may be useful in the process. With the rule background and data sources in hand, Henry Gutierrez will provide some concrete examples of how to pull together, format, and display the machine-readable file. Finally, Fred Stodolak will present and discuss 3 options for the consumer display and considerations for the near future, and then we'll open it up the floor for questions and provide answers where we can. So what we're going to start with is a polling question. Our first polling question is, where on the journey to complying are you? And you can make one of 3 selections. You've not yet begun, you're just getting started, you're midway through the process, or you're complete or fairly near completion. Well, that's some pretty interesting results. So let's get started. First, to make sure we're all operating from the same baseline, let's discuss the rule requirements. There's really 2 broad requirements. The first is that annually, hospitals must provide a machine-readable file containing negotiated charges, basically payment rates, for all items and services. The second is for 300 shoppable items and services only, including 70 which have previously been defined by CMS. If provided by the hospital must provide a consumer-friendly display of gross charges and negotiated charges. And just a note on this, that employed hospital physicians and non-physician services must also be included. So if we move on to the specific requirements for both the machine-readable file and the consumer display, following elements must be included: description of the item or the service, the specific code, and that could include HCPCS, MSDRG, ICD-10, NDC, for example. The de-identified lowest and highest negotiated rate, the negotiated rate and or charge for all payers, excluding those federal payers, but including Medicare and Medicaid plans negotiated with third-party insurers, and also direct contracts with employers. Inpatient versus outpatient setting must also be disclosed. And if the provider has a self-pay discounted charge, that also needs to be provided. So let's talk a little bit about the recommended timeline. And we've been dealing with this issue with our clients going back to March of this year. We've been advising the providers we've been working with that to do a quality job, the ideal time frame would be to pull the data together no later than September 15th, as seen on the chart, with the shoppable list completed by September 30th. Our feeling is this would allow for time to perform pricing analysis and possible realignment and for production of machine-readable file. We think it's important that if you look at those services early on, you can identify whether you may have some competitive issues with those prices and give yourself time to realign those prices. And then we think that the machine readable files should be completed between October and early December, followed by time to integrate the data into the consumer display and estimation system. So you can see it's a fairly complex process that could take quite a bit of time. So let's talk a little bit about, for those of you that are just beginning, and what our recommendations would be. Focus on the data integrity, not necessarily the speed. We believe it's more important to be accurate with the information provided than try to rush to get 100% complete and 100% compliant. Consider prioritizing payer contracts, focusing first on those representing, let's say, 80 to 90% of your volume or revenue, and deferring those without any or minimal volume or revenue for the past 12 months. If you don't comply by January 1st, or only have your largest payers completed, you'll have time to update or implement the consumer display machine readable file as CMS. It's our understanding CMS will first warn your organization as to its non-compliance and may ask you for a corrective action plan. So you can then submit your plan, status, and timeline and show them that you're well on your way to meeting requirement. Ultimately, after an appeal process, the penalty right now stands at $300 per day, which comes out to about $109,500 per year per hospital. For those choosing not to comply, you may face some public relations issues. And we've already heard from some of our clients that they've been contacted by some of the public advocacy groups in terms of what their intent is to comply with the regulations. So I think that's important to keep in mind as you look at developing your price transparency. All right, we're going to move on to polling question number 2. Fairly straightforward. Does your organization expect to be fully compliant by January 1st, 2021? Yes or no? Okay, we want to move now on to 10 things you need to know. And this is based on our experience and having worked with clients, again, since back into March. Number 1, hospitals must develop a unique list of shoppable items taking into account either volume or revenue. One list for all hospitals within a health system will not comply with the rule. There has to be a list for each hospital within the health system. CMS recently clarified that for smaller hospitals, those unable to identify 300 shoppable items, they must at least show all shoppable items offered. We found including shoppable items with at least one encounter in the past year has allowed us to arrive at or come very close to the 300, even for our smaller provider clients. Another note, the shoppable list is not simply items from your charge master. MSDRGs, outpatient surgeries, ED visits, and other package services are expected to be on the list, and they're also included in the 70 that are required by CMS. Let's move on to number 2. CMS rule does not require patient estimates and only requires gross allowable amounts. The patient out-of-pocket estimates will exempt providers from complying exactly with the consumer display, but not the machine readable file requirement or the 300 shoppable items and service requirement. And payers and employers will still have access to all negotiated rates and charges for all items and services despite the exception. Consequently, hospitals should not get a false sense of security that payers or employers will not have access. Again, I think that's an important point to make. Moving on to number 3. Complying with the machine readable file requirement is really the most onerous task as we see it that hospitals are going to need to put in place. It's not simply the charge master, as I mentioned before, but it includes item description, the code, any gross charge, the negotiated rate or charges, and also the de-identified minimum and maximum for all items and services. An important point. CMS also recently confirmed in our discussions with them, and it's been publicly released, that all payer contracts, regardless of recent activity, must be included. So what this really means is that while 80 to 90% of your revenue may be driven by the old 80-20 rule, by 20% of your contracts, the other 80% of your contracts must still be included in the machine readable file. A warning too, hospitals beginning at this late stage, however, would be wise to focus first on those contracts representing the bulk of their revenue, as I mentioned previously. The file, where applicable, needs to include MSDRG rates, per diem rates, whether there's an APC, EAPG, ASC, or other rate of negotiated terms you may have with some of your payers, percentage of charge amounts and the terms related to those. In terms of drugs, NDC level drug charge, the rate, and also the related implied quantity, HCPCS level fee schedules, self-pay discount amounts, and a myriad of other terms and rates that have been negotiated. So as you can see, it's a pretty extensive amount of information that has to be provided. For those providers working with vendors, you should request a user-friendly version of the machine readable file to validate the accuracy. I think that's an important point. As you can see, there's a wealth of information in that machine readable file. And so you should ensure that you're getting that in a format that you can review and validate that information. So now let's talk about number 4 for a minute. Whether it's in the consumer display or the patient estimation system, hospitals must include, for example, MSDRG 470, which is a hip and knee replacement procedure, and it's on the CMS required shoppable list. And they must show not only the negotiated charge, but also the de-identified lowest and highest negotiated charge. You can see in this example, and I know the screen may be difficult to see, but you can see that in example, payer A is paying a per diem and then has other payment provisions in terms of just a per diem. Payer B is paying a straight percentage of charge, and payer C of these 3 payers is the only payer paying based on an MSDRG methodology. Even payer C, in the case of being paid on the MSDRG, has a carve-out and other payment provisions. The final rule, taken literally, would require or allow providers to disclose the rate shown and highlighted here in yellow. Again, you can see the information for each of the payers. Clearly, providing this information, especially for the per diem plus the carve-out and the percentage charge payers for A and B, would not be meaningful to a consumer, since they would still have no idea what the expected length of stay is or the amount of charges generated for their particular stay. Accordingly, while not specifically required in the final rule, and perhaps not as important for the machine readable file to provide the consumer with really meaningful information, and we think that's an important point, and ensure that the displayed de-identified low and high negotiated charges are comparable and inclusive mathematically for all the payers, our company regroups all inpatient records to an MSDRG and calculates and displays a negotiated reimbursement regardless of the method, being on a per diem, percentage charge, DRG, or other basis. Our feeling is this then provides really an apples to apples comparison. At the bottom of the sample, highlighted in green, you can see in an equalized manner the comparable negotiated all-inclusive allowable reimbursement that would be most beneficial to the consumer. Again, you really can't compare a per diem to a percent charge to a DRG without doing this type of calculation. So below, what you can see is that the all-inclusive average allowable inline reimbursement is $29,000 for payer A, $42,000 for payer B, and $48,000 for payer C. Clearly, looking at it this way, these calculated amounts are more meaningful to the consumer than, as I mentioned, looking at trying to compare per diem to percentage of charge across different payers. So again, if I haven't confused you enough at this point, let's talk about number 5. Gross charges and pharmacy prices at NDC level are recommended. Okay, so charges are still required, and since all items must be disclosed, our interpretation is the NDC and the implied quantity must also be provided in the machine-readable file. Each year, we would recommend that you look at pharmacy best practice gross and net rental price modeling and implementation prior to providing your annual update for the transparency regulation. Each year, we also recommend chargemaster restructuring, where if you can, you have the ability to lower your shoppable items to be more price competitive in your marketplace, utilizing updated contract information, projected volume, case mix, unit cost, and market data to go into that update. Right, as we look at number 6, rules applies regardless of Medicare participation. So I think it's important, and I think early on people thought this might just apply to acute care hospitals and the like, but the rule applies, it's regardless of participation in the Medicare program. And it includes, as you can see on the list, critical access hospitals, inpatient psych facilities, be they salt community hospitals, even inpatient rehabilitation hospitals, long-term care hospitals, and other specialty hospitals. So you can see it's a pretty comprehensive regulation applying across the board to healthcare facilities. Number 7, negotiated rates for federal payers, basically Medicare and Medicaid, are not required, again, since that information is already readily available. However, negotiated rates for commercial Medicare and Medicaid plans plus non-Medicare plans, including contracts with employers, must be included. All right, so that's an important point to note. Also, with the recent IPPS final rule requiring grouping of data to common MSDRGs and calculation of median Medicare Advantage and allowable payment levels. Accordingly, what we're suggesting for our clients is we're processing their historical claims and we are regrouping all inpatient claims through the MSDRG grouper and performing these calculations as I noted before. As to number 8, the rule excludes non-hospital sites of care, such as ambulatory surgery centers. However, it does require inclusion for items and services provided by hospital-employed physicians and practitioners. And we had this defined. Employed physicians and practitioners are basically those that are not independent contractors that you may be billing for, but they are considered employees if you're withholding federal income tax and paying Social Security benefits for them. Number 9, hospitals located in Puerto Rico, District of Columbia, Virginia Islands, Guam, American Samoa, and Northern Mariana Islands must also comply with the rule. So it's not just the United States, it's also all of these other countries and areas that need to be included within the regulation. So now as we move on to number 10, important note that section 2718E of the Public Health Service Act requires each hospital operating within the United States to establish and update and make public a yearly list of the hospital's standard charge for items and services provided by the hospital. And this includes diagnostic related groups established under the section. Standard charge has now been defined by CMS to include the gross charge, negotiated charge or payment rate, discounted cash price, and the de-identified lowest and highest negotiated amount with third-party payers. So just a word of caution here. When you see the term standard charge referred to by CMS, remember that this is not simply the gross charge master charge, again, that many hospitals had to publish in the past, but is both the gross charge, but also an important point here, it's the discounted price and negotiated amounts with the third-party payers. So it's much more information being provided to the public. For purposes of providing more meaningful de-identified minimum maximum negotiated allowable amounts to the consumer, providers are, and simply to comply with the regulations, providers may need to group or crosswalk their historical claims and negotiated rate and gross charge data to an MSDRG each year, regardless of what the payment methodology may be for that particular payer. And as I stated earlier, calculating the median Medicare Advantage negotiated rate by MSDRG will be required beginning with the 2021 Medicare cost report. Now, I would like to turn the program over to Renee Clark from Phoenix Children's Hospital, who will provide a provider's perspective.
Thank you so much for inviting me. I'm excited to share with everyone what our experience as a provider working with Panacea has been like. Before I describe the approach that our organization took as it relates to transparency requirements, I would like to tell you a little bit about Phoenix Children's. Our main campus is a 433-bed pediatric hospital located in Phoenix, Arizona. We have approximately 525 employed physicians with 33 primary pediatric specialties and 55 pediatric subspecialties. We provide more than 13,000 inpatient, 327,000 outpatient, and 138,000 emergency and urgent care visits each year. Our hospital and clinically integrated network have been recognized for cost efficiency and quality, including being recognized by U.S. News and World Reports as one of the best children's hospitals in the country. Earlier this year, before it was even apparent whether the rule would be delayed or possibly even terminated, we knew that we must start preparing to comply with CMS requirements. We were already considering a new vendor for our annual Charge Master review, and we used this opportunity to evaluate solutions and alternatives related to price transparency. In May, we selected Panacea Healthcare Solutions to assist us with this initiative. We executed an agreement that we felt provided the most comprehensive approach and also allowed both Phoenix Children's and Panacea sufficient time to prepare for implementation by January 1st. Specifically, our goals were to complete a full analysis of our Charge Master, develop the compliant machine-readable file, and create a compliant shoppable services tool for consumer use. Our first step was for Panacea to assess our Charge Master data integrity to ensure our coding was up to date, complete, and compliant. The next step is to ensure that our Charge Master prices are rational and defensible, including gross and net revenue modeling to understand the impact of all changes. This process includes a concurrent review of our historical claims, payment data, including 837 and 835 data, and peer utilization to identify our top shoppable services. All payer contract terms, including contract rates, fee schedules, and other pricing rules, are included in the evaluation. Panacea creates a file that contains gross charge, contracted allowable reimbursement, and payment profiles for all items and services. This work to develop the full machine-readable file also provides the information necessary for the consumer display and estimation system that we're developing. So where are we today? I'm happy to say that our Charge Master coding and compliance review has been completed. I also cannot stress enough how impressed we've been with the Panacea team's understanding of data, recognition of the importance of data integrity, and willingness to dive into the weeds to understand and ensure appropriate interpretation of our data and our contracts. We recently finalized our shoppable services list, which includes 294 CPT and HCPCS outpatient procedures, 27 MSDRGs, which equates to 52 APR-DRGs, and 3 COVID testing codes to facilitate the required posting of the COVID testing cash prices. The shoppable list has been loaded into Panacea's hospital zero-based pricing system, and we are moving to a near final pricing model. The CDM pricing model strategically evaluates each code, applying criteria such as peer position, peer average rates, CMS rates, and our internal data. We have been able to maintain our overall favorable market position while significantly reducing those prices where there were more than 30% above market. And we accomplished this with a higher net revenue than we would have realized if we had done a simple across-the-board price change method. Panacea has created our first pass of the machine-readable file, and it's 95% complete. We just have a few outstanding items to be pulled in, including our drugs and employed physician standard charges. Because we have most of the data pulled together in the machine readable file and have finalized our shoppable list, Panacea was able to also do a first pass on our consumer display. The next few slides are mocked up samples of what that tool looks like. This is just a sample of the consumer display that is being built out. This first screen shows where the consumer searches for procedures by description or code, as is required by the rule. Next, the consumer can select inpatient, outpatient, same-day surgery, or all, which is another requirement under the rule. Next, the consumer enters their insurance information to be directed to the applicable negotiated rates. If they don't have insurance, they will be directed to the self-pay discount amounts, whose disclosure is also required under the rule. Panacea has offered a few options related to member cost share that Fred will be going into in details later. Under the option that Phoenix Children's has chosen, the consumer can enter their cost share information if they know it, which includes copay, deductible, and co-insurance estimates. This will allow us to display not only our charges and contract allowable, but also a patient portion estimate. Panacea is also offering an option that would automatically pull that information into the system from a third-party vendor. This is an option we are considering as well. This page is an example of the results screen. For this example, we've used an MRI procedure. As you can see to the far right in the payer information section, the total charge is about $11,000, while the contract allowable is $6,350. The estimated primary insurance portion and the patient responsibility are displayed based on the information entered by the consumer on the prior screen and as shown in the header above. The in-network and out-of-network information in the center of the screen includes de-identified minimum and maximum negotiated rates. This information is not required under the rule, but is an option that gives providers the opportunity to determine how much additional information they would like to display beyond those minimum requirements. At this time, we do not intend to include these optional fields in our display as we feel it may increase confusion for our consumers. While we have made significant progress since May, there is still work to be done. We are performing some additional stop-loss and lesser-of modeling to ensure the new charge-master impact is fully understood. We are adding those drug and employed physician standard charges that I mentioned earlier. And we fully expect to be doing a final validation of the machine-readable file and consumer display data in November and early December, with the goal of being ready to implement in late December. For the future, we intend to expand our strategic pricing, especially for commodity services. We are also considering how quality data and comparative financial data can be integrated into the consumer tools to ensure comparisons are meaningful. We're looking forward to continuing to partner with Panacea in this space. I'll go ahead and turn it back over to the Panacea team to discuss the data and data sources required.
Hello, everyone, and Renee, that was a great presentation and very insightful, and I'm sure our audience is going to take a lot of good information from that back to their organization. What I'd like to do now is talk to you about some of the data and the data sources required or that you might find useful in the process of complying with the rule at your own organization. So what we're recommending in terms of data is that we pull together payer contracts that would include all the terms, the rates, and the fee schedules. We're recommending that we pull together the charge master, but that would also include the employed physician and practitioner fee schedules if that applies to your organization. We are also recommending, as Greg mentioned, NDC and implied quantity level charge data. We've had some hospitals ask us why that's required, and quite frankly, it's because the rule does require in the machine readable file that all items and services be included and the charges. And to get the most accurate level of information, then we would want to include that information at the NDC implied quantity level. We also recommend pulling in 837 data, 835 data, and payment data, and at least 12 months of historical data is recommended. You'll see how this all comes together. And then if you have supply data, if it's not already included in the charge master, then similar to pulling in information from your pharmacy system at the NDC level, it may be necessary to pull some supply charge data together. So what I'd like to talk about now is how to pull together the shoppable list and format the machine readable file in a compliant manner. with all that information, what we're recommending hospitals do is pull that claims, that payment data, the contract data, and even the other information that I listed on the previous screen into a database. You might want to use a SQL database. We're using a SQL database to pull that information together. Once you have that information together, especially including the claims data, it does provide an opportunity to then process the 12 months worth of claims data, what we call a disaggregation algorithm process. So what we're doing is taking that claims data, and we've already developed, identified with tables, HCPCS codes, DRGs that are shoppable, and what we're doing is we're disaggregating that population of claims data between items that are clearly excluded. In other words, they're not shoppable, and then we're segregating them, we're disaggregating them to those that are shoppable. But we actually take it a step further, and we break it down at the patient type level in a way that aligns with payer contracts. For example, we take those shoppable services and break down the inpatients. We break out the outpatient surgery cases. As you know, many payer contracts will have DRG rates or per diems, and we have outpatient surgeries that are typically case rates. We even have a category for ED, and again, many hospitals have ED level contracts. And then, of course, we've got our private outpatient data as well. And again, this aligns with fee schedules or with case rates or with per diems or DRGs. And of course, the reason we are using claims data as well is twofold. We do need to take into account, the rule does say that you need to take into account volume or revenue in the process of selecting your top shoppable items. So by having a history of at least 12 months, we can identify the top shoppable items. And again, by breaking it out into these patient type categories, then we now know that we can align it with the payer contract terms more easily for purposes, especially of the consumer display. The nice thing about processing that claims data is we can also simultaneously create what we call charge, payment, and allowable reimbursement profiles. So while we're processing that data to identify the shoppable items, your organization, what you can do is what we're doing similarly, is to create these charge and allowable payment profiles not only for the shoppable items, but even beyond that. And you could break it down between in-network, out-of-network. You could break it down at the payer plan code level. And the rule does require you break it down between the inpatient and outpatient service areas. And as I mentioned on the previous slide, we're actually taking that a step further and breaking it down, the outpatient down between outpatient surgery, ED, private outpatient, and so forth. As Greg mentioned before, once you have your shoppable list and you've created those profiles with both charges, for packaged services would be included in that, as well as the allowable reimbursement. One of the things that Greg mentioned is we are recommending taking a look at your pharmacy charges, your hospital charges, and if you have the time, to realign that, especially with a focus on shoppable services, to implement some kind of strategic pricing or zero-based pricing process. It's not required, it's just recommended. So now at this point, you've got your data together and you're ready to produce your machine-readable file and your consumer display. I'm not going to spend a lot of time on this, but this is just some sample output from that process, which is to first identify the shoppable services. This is an example for private outpatients. And what you see here is the HCPCS codes. We're showing the volume. We're showing the revenue. And as I mentioned, the rule does require that you consider volume and revenue in the process. And you can see here that we've only identified those HCPCS codes from our tables that have been identified as shoppable. And by looking at the revenue and usage, we could pick those that are the top shoppable items. And if you'll notice, this green item here, and this green item here, this is a CAT scan here where it says yes. Those items in green here that say yes mean that they are on the top list of 70 defined by CMS. So immediately we now know that these are on the CMS list. They do have significant volume, but all these other items in yellow are candidates to be included in that list of 300 shoppable items. When you process the data, you can add some additional statistics like we're doing here. For example, this CAT scan, you can see the word single here. This is saying that 86% of the time, patients having this CAT scan are only having that one test at the hospital. In other words, the test is not being provided in conjunction with other items that are in our charge master. And you may want to keep things simple in terms of how you present the data. You might want to choose more of those items if you have the volume to support that. The rule does require that if you don't have activity, you don't offer all those 70 items by CMS, that you need to disclose on the consumer display that those services are not offered at your hospital, and you need to make up the difference. And you can see here, this hospital here, these items, orange, are on the CMS list, and there's no volume and usage. There's no volume or revenue here. So we know immediately after processing this data, that we have to make up for those items not being in our offered in our charge master. So we do recommend that you take a look at the coding to make sure you don't have some coding issues causing this issue. This is an example of outpatient surgical items. If you notice, and Greg had mentioned this earlier, I think, that the rule does require or certainly imply that it's not just charge master items, that you would expect to see DRGs, you would expect to see outpatient surgeries, and one reason, as you can see here where it says yes, is that CMS on its own list of 70 has included outpatient surgery items as they did DRGs. And here's a knee arthroscopy procedure, and you can see there's quite a bit of volume and revenue, and it is on the CMS list. All these other outpatient surgery items are candidates to be added to the shoppable list. Again, this comes from processing that 12 months worth of data. So, we have another polling question, number 3. So here's the question. Has your organization already developed a unique shoppable list for each hospital within your health system? Remember, if you have a health system, the list does need to be unique. So it's a simple yes or no answer. Great, that's very good. That's very good. Let's talk about the machine readable file. We just talked about how to use that data to develop your shoppable list. And as Greg mentioned, it's not simply a charge master. And one reason we're emphasizing that is because earlier in the process, in talking to hospitals, we would start our phone calls, and they would refer to this machine readable file as a charge master. And so we just want to emphasize the fact that it's not simply a charge master anymore as it used to be. So the machine readable file should include a hospital charge master. It should include the employed physician or practitioner fee schedules used for billing. Of course, the rates, the negotiated rates associated with that as well. It should include the negotiated rates, the standard charges by HCPCS code, Rev code, MSDRG, and so forth, and of course the drugs and supplies, regardless of the presence in the charge master. So you might have to go to some of those subsystems, as we mentioned earlier. So I just wanted to show you what a machine readable file looks like, and there are a few formats. I have 2 examples here. This is what a CSV machine readable file format would look like, and that is acceptable to be on your website based on the CMS requirements. And this is a JavaScript format. And the only reason I'm showing this to you is so you can see that if you were working with another company like ours or some other company or with an IT company, this is what the actual file would look like. And as Greg mentioned earlier, clearly this is not something designed for a human being to be validating the accuracy of the data. So what we're recommending is that this information be put in a more user-friendly format for validation purposes, of course, so that you can verify or spot check some of the data before then creating the machine readable file. So with that, I am happy to hand it over to Henry, and he's going to show you some samples of what a machine readable file might look like at your organization. So, Henry?
Thank you, Fred. Okay, so this first slide displays the format Panacea utilizes, and while CMS does have a required file name, they have not provided a standard format allowing providers to have some flexibility and poetic license on how to present the data. We have elected to display the payer plans vertically and with the required fields horizontally to allow for quick filtering and visual data validation without the need to scroll off and to the right. You can see in this example that the billing code can represent the charge master item or a HCPCS, DRG, or even an APR, DRG, EAPG, and NDC as applicable. We display, as required, the service area as well as the various negotiated rate methodologies, allowing the user to validate the data by payment method. On the next slide, we have an example of how you can present the data for a payer contract that includes varying per diem rates for inpatient services by revenue code. Note that the inpatient versus outpatient service fields as required by CMS, and note that we display this in applicable charge master lines for the respective payer plans. The next slide is an example of how we present the base rate by MSDRG for those payer plans where MSDRG rates were negotiated. Also note in this example the de-identified minimum, max displayed as required. Note that the gross charges are calculated from the claims data, representing the average charges for the package service where claims experience does exist. While the median is not a requirement for the machine-readable file, we do include and regroup all claims, regardless of how they are paid, APR DRGs, for example, to meet Medicare cost reporting requirements. On this next slide, while CMS certainly doesn't expect hospitals to license an EAPG or ARPR DRG grouper or pricer, we are displaying the base APR DRG with applicable markups for Medicaid contracts negotiated with third parties, and you may want to consider doing something similar. Okay, on this next slide, here's an example of how we are able to display ED case rates based on ED levels. Note that we display this as an outpatient emergency service area while also disclosing the rate as a case rate. And then similar to the ED case rate, this is an example of an outpatient surgery case rate. And again, note that we have disclosed the outpatient service area, the rate methodology, and the negotiated rate along with the required description, HCPCS code, the identified max and mins. Next, for private outpatient services paid on a fee schedule, you can see here that we have displayed in the charge master negotiated per unit rates. For rates not found in the charge master, for which we have negotiated rates, we display such rates by HCPCS code. We give clients the option of showing the negotiated percent of charge itself or the calculated amount. Here we display the negotiated percent and show the fee off to the right. Next example is the percent of charge. Here we also give clients the option of showing the negotiated percent of charge itself or the calculated amount, and you may want to consider those options as well for your machine-readable file. Next, for percent of charge carve-outs, CMS only requires that we show the base rate. However, there may be carve-outs, and we do recommend disclosing the carve-out terms as you see here. On the next slide, off to the right of the worksheet, it's important to show you that we have integrated the historical 12 months of claims data with the contract data to facilitate the calculation of all-inclusive negotiated, estimated, or average negotiated allowable reimbursement for private outpatient, ED, and outpatient surgery cases. We do this along with flagging in the same file those items that are shoppable. The lower grid is an example of the various drug and supply carve-outs that may contribute to an all-inclusive payment beyond the base rate. All-inclusive estimates also include any stop-loss or lesser-up provisions. It is this information that we provide in the consumer display to provide the most meaningful information to the consumer. And with that, Fred, back to you with more on the consumer display.
Oh, thanks, Henry. That was great information. And yeah, as Henry mentioned, in producing the machine readable file, Henry just showed you some fields that are not required for the machine readable file, but it is information that off to the right he had showed you for the shoppable items, the all-inclusive negotiated rates for each of those payers and each of those services. And what's nice is you could see where this all comes together, and now that information could be used to feed the consumer display. And what I wanted to discuss is that there are probably three options that you might want to consider for the consumer display. So let's talk about the first option. The first option is simply to meet the minimum requirements. And the minimum requirement is that hospitals show the gross allowable negotiated rate. In other words, to meet the minimum requirement, it's not necessary to give the patient an estimate. So in other words, you don't have to provide a payer and a patient portion estimate. It's only the gross allowable rate that must be displayed to meet the minimum requirement. However, if you take that route, you will have to show the de-identified minimum and maximum negotiated rate alongside that specific payer's negotiated rate for that specific service. And of course, along with the description and some of the other information related to that procedure. So some of the pros and cons I'd like to share with you of this first option, which is the minimum requirement option. And the first is that the allowable negotiated rates are certainly less consumer friendly. And so that would be one reason to maybe do a little more than the minimum requirement, is just simply to provide something more user-friendly, more consumer-friendly. The other thing is that if you were to take the rule literally, just like Greg mentioned on that one DRG 470 example, it wouldn't be consumer-friendly to just simply show the negotiated per diems or the negotiated percent of charge terms. So again, to meet the minimum requirement, one could argue that that would be sufficient. But again, it wouldn't provide meaningful information to the consumer. And as Greg showed you, it would be probably worthwhile to go through the step of applying those terms to claims data to provide a more useful estimate, even if it is at the gross allowable level. And then, of course, the de-identified minimum and max may not necessarily be comparable to the extent of differences in provisions. So you might have a base DRG rate for one payer that doesn't include the same carve-outs as another payer. And so that's one of the flaws that we see with this de-identified minimum and max requirement. But again, if you were to use an all-inclusive rate, such as the example Greg showed you, then you wouldn't have this issue, and you wouldn't be confusing the consumer either. By providing the gross allowable amount, it does, however, reduce the risk of providing an estimate, not reflecting the actual level of care, that's provided to the patient. Let's go to the second option, which is to slightly exceed the requirements. To slightly exceed the requirements, you might want to include the gross all-inclusive calculated and estimated allowable negotiated rate, as we just discussed. We might want to show the estimated payer portion and the estimated patient portion, payer portion and patient portion based on their own entry of the copay or coinsurance and deductible amounts. And by doing that, you would not be required, you'd be exempt from having to provide the de-identified minimum and maximum on the consumer display. And of course, the description. So some of the pros and cons: it is a more consumer-friendly. It would be a more meaningful than simply the negotiated rates or terms. It's a benefit not to be required under this option to show the de-identified minimum and maximum. However, there might be a little more risk of final billing being far different than the estimate provided due to complications or changes in physician practices or ordering. And but of course, that's what disclaimers can be used for as well. So let's talk about option three. Option three would be to greatly exceed the requirements, and under this option, we would provide the gross, all-inclusive, calculated, and estimated allowable negotiated rate. It would be the same thing, the payer portion, the patient portion. And mainly the difference is that under this scenario, we're actually going to import that copay, coinsurance, and deductible information from an eligibility vendor. Okay, so that would be imported directly into the system, not having to rely on the consumer to do that entry. And of course, this would be more accurate and slightly more expensive for you to go that route. And of course, all these same options do apply as an option two in terms of pros and cons. So, real quick, I'll just run through some sample consumer displays. This is just, it is required for the consumer display that the consumer be able to enter a description or a code, and that's what you're seeing here. The setting, it is required to disclose the setting. You can see we're allowing consumers to search all settings or drill down immediately to the setting that they're looking for. If there is, this is an example where the patient has no insurance. So if the consumer has no insurance, it would bring you directly to the self-pay discount amount if the hospital has a self-pay discount plan. And here's an example where the consumer does have insurance, United Healthcare, the HMO plan, and again, this copay or deductible could be entered or imported electronically, and we do have to allow the consumer to select the location. And then, of course, this screen shows the consumer entered 73721 for an MRI, and all this information is not required. And I wanted to point out what is required under option one. Okay, so here's your minimum. This 32.45 would be the minimum negotiated rate. This 67.43 would be the maximum. And under that minimum requirement option we discussed, it would only be this 63.50 that would be displayed. Okay, so under that option, that's the minimum requirements. If we wanted to give the payer portion estimate and the patient responsibility estimate, that's this other information you're seeing here. The out-of-network is not required. It's I know with our clients we just provide that as optional in case they want to provide someone that's out-of-network, with some information. Of course, mobile device options are nice to provide the consumer as well. And hopefully that was helpful in showing you how to create the shoppable list, how to process the data, and how to bring together all that information, not only in the machine readable file, but in a way that could be brought forward on the consumer display. So we have polling question number 4. So here's the question. Does your organization plan on providing the optional patient out-of-pocket estimate? In other words, does your organization plan on doing what we were referring to as option 2 or 3? It's a simple yes or no. Great, thanks for providing that information to everyone. So what about the future? January 1 is not too far away, and we expect that once these negotiated rates are out there, not only for the public, but for employers and for payers to see, that there will be ramifications in strategic changes, your organization to adapt that will have to be made. And so I just jotted down a few things that we might expect in the future. So the first one is, there certainly could be significant downward financial pressure from payers with higher rates. You know, you might have one payer saying that they're paying more for a hip replacement than another payer. And so when the contract comes up for renewal, that might create some negotiation pressure. And, and during that process, there's going to be an increased importance, right, for good profitability modeling at that payer plan code, that payer product level for each of those items and services. So there's clearly going to be increased importance to do what-if modeling, and we would recommend that process start, in the first half of next year to be prepared. We do expect with all this information out there that you're going to see much more comparative benchmarking as we see now for charges, but we're going to see good comparative benchmarking for negotiated rates. And that's something that's going to be an outcome of this information being out there. And so hospitals probably should look at how their negotiated rates, especially for their top shoppable items, compare and get a good sense for that. We had one client recently said that they know that there's going to be some payers with higher rates for certain procedures than other payers, but that even that higher rate is lower than what they're expecting to see from the hospitals in their area. So with that information, it could be helpful during that negotiation process. We are expecting the incorporation of quality data or comparative charge and negotiated rate data to be included in the consumer display where it's feasible and where it's favorable to your organization. CMS did in the proposed rule and in the final rule hint to the fact that they could have required more than 300 shoppable items, and so that might be something we see in the future, is that the shoppable list count requirement might go up from 300. And we already know that there's a strong possibility that CMS may in the future require some the use and integration of quality and other benchmarks. So we're coming around the home stretch here, and I think this is our last polling question. Do you think your organization will add quality or other comparative benchmarking data to the consumer display or your estimation system in the future? Again, it's a simple yes or no. Oh, great. That's excellent feedback for our audience. And I think at this point, we'd like to open it up for any questions, any answers we could provide. And if there's anything we can't confidently provide answers on, we'd be certainly do a little research and get back to you.